Hey everyone, and welcome to this explainer. I want you to think of the human cardiovascular system as an incredibly complex, high-performance engine. It's an engine that has to run continuously, 24 hours a day, 7 days a week, from the exact moment you're born until the very end of your life. It literally cannot take a break. But what happens when that engine starts to falter? Well, the moment the heart's blood supply is compromised, a high-stakes, invisible ticking clock begins. Every single second matters. So today we're going to break down the exact science of cardiovascular emergencies. We'll track what's happening inside the body when the heart is under siege and look at how rapid intervention can quite literally rewind that ticking clock. All right, let's just dive right in. We've got a roadmap here to trace a heart emergency from the microscopic level all the way to a full-blown rescue. We'll cover the anatomy of a breakdown, the heart attack spectrum, assessing the emergency medical care, and finally, surviving cardiac arrest. Starting things off with Section 1, Anatomy of a Breakdown. This is all about the silent buildup happening right inside the vessels. To really understand a cardiac crisis, we have to recognize that the emergency often starts years or even decades before the actual sirens sound. It usually kicks off with a condition called atherosclerosis. Basically, this is a disorder where cholesterol and calcium just continuously build up inside the walls of your blood vessels. And as this plaque accumulates, it drastically narrows the lumen, which is just a fancy medical term for the inside diameter of the artery. Think of it like a pipe in your house slowly getting clogged up with rust and mineral deposits. When this happens in the coronary arteries, the literal plumbing that carries blood and essential nutrients to the myocardium or the heart muscle just becomes totally choked off. And this brings us perfectly to our next concept, ischemia. When that plumbing gets blocked, the heart muscle essentially starts starving. Ischemia is that lack of oxygen that deprives the tissues of necessary nutrients because of the blocked blood flow. You can really think of ischemia as this desperate physiological cry for oxygen from the heart. But hey, here's the critical piece of good news. Ischemia is actually potentially reversible. Because permanent injury hasn't happened quite yet, if we can just get that blood flowing again, we can absolutely save the tissue. But if that cry for oxygen goes unanswered, we cross a really devastating threshold into infarction. Infarction means the actual death of a body tissue, usually because its blood supply was cut off for too long. And unlike ischemia, infarction is not reversible. No way. Once those cardiac muscle cells die, they are gone for good, period. This right here is the brutal cost of that ticking clock we talked about. When the clock runs out on ischemic tissues, infarction is the tragic result. Moving into Section 2, the heart attack spectrum. We're going from the early warning signs into an acute crisis. So now that we know what's happening anatomically inside those vessels, how does this actually look and feel for the patient? Well, it triggers a group of symptoms caused by that myocardial ischemia known as acute coronary syndrome, or ACS. And on this spectrum, we've basically got two main players. The first is angina pectoris. This is that transient, short-lived chest discomfort caused by a partial or temporary blockage. It's a huge warning sign for sure, but the pain does eventually pass. The second one is an acute myocardial infarction, or AMI. This is what we all commonly call a heart attack. This is where the blockage results in the actual death of the heart muscle. By the way, the word acute in this context just means it's new, or it's happening right this second. And because infarction means permanent tissue death, medical pros live by one absolute rule: time is muscle. During a massive crisis like an AMI, the heart's rhythm can get seriously messed up. On one end of the extreme, we have bradycardia. This is defined as a dangerously slow heart rate. We're talking less than 60 beats per minute. At this stage, the heart is just flat out failing to maintain the speed it needs to circulate blood effectively. Now, what's really fascinating is the total opposite extreme, tachycardia. This is a super rapid heart rate, over 100 beats per minute. What's happening here is that during an emergency, the body's autonomic nervous system, specifically that sympathetic fight or flight side, just totally panics. It senses a drop in cardiac output and furiously signals the heart, telling it to beat faster and faster to compensate for the failing system, which basically pushes the heart rate into a dangerous overdrive. All right, Section 3, Assessing the Emergency. This is where we become the medical detective. When first responders show up to a suspected cardiac event, they have to size up the situation instantly. They do a primary assessment, get a precise history. Put yourself in their shoes for a second. You arrive on scene. You've got a patient clutching their chest in serious distress. Time is muscle, right? So how do you actually decode their chest pain to figure out exactly what's going wrong inside their body before it's too late? Well, responders use this brilliant, highly structured tool to solve the puzzle, the OPQRST mnemonic. It's super practical. O is for onset. When did the pain actually start?
P is provocation or palliation. What makes it feel better or worse? Q is quality. How does the patient describe the pain? Is it heavy, crushing, sharp? R is region and radiation. Where exactly is it? And does the pain travel, like up to the jaw or down the arm? S is severity. On a scale of 1 to 10, how bad is it? And T, timing. How long has this whole thing been going on? These aren't just random questions, they are quite literally the universal toolkit for cracking the code of a cardiovascular emergency.
Let me show you exactly why OPQRST is such a game changer. Imagine comparing an AMI to a dissecting aortic aneurysm. An aneurysm is this crazy condition where the inner layers of the aorta literally separate and high-pressure blood forces its way between the layers. If we use our OPQRS assessment, the contrast is incredibly stark. An AMI usually has a gradual onset, kind of a feeling of tightness or pressure that might ebb and flow. But an aneurysm, that hits with a sudden, maximum, tearing pain instantly. The clinical signs are night and day, and catching those differences dictates absolutely everything about whether that patient survives. Which brings us to Section 4, Emergency Medical Care, fighting the clock and supporting the heart. Once the assessment is locked in, medical providers have to jump into action immediately to stabilize the patient. One of the primary interventions is giving a medication called nitroglycerin, and the mechanics of how this works are just incredible. Nitroglycerin actively dilates the coronary arteries. It literally widens the tubular structure of the blood vessels. By forcing that lumen open, it improves blood flow right past the blockages and straight to the heart muscle. It's basically a direct counterattack on that ischemic cry for oxygen we discussed earlier. So, the crucial point here is that if we fail to intervene fast enough, we get these catastrophic, cascading systemic failures. Just look at the potential consequences of an AMI. You could end up with cardiogenic shock, where the damaged heart simply lacks the raw power to pump blood through the system, leaving the tissues completely starved of oxygen. Or the patient might develop congestive heart failure, or CHF. This is where the heart loses its pumping effectiveness, and fluid aggressively backs up into the lungs or pools in the lower body, a classic sign we call dependent edema. It's a dangerous domino effect. To stay ahead of these cascading failures, paramedics rely heavily on advanced cardiac monitoring. This involves placing electrodes right on the patient's chest to set up an ECG. The ECG tracing is vital because it lets medics physically see the electrical activity of the heart muscle in real time. But they have to be super meticulous. They need to be able to tell the difference between real, life-threatening dysrhythmias and mere artifacts, which are just false, messy readings caused by outside interference, like a patient simply shifting around or moving. Finally, we reach Section 5, Surviving Cardiac Arrest, the ultimate intervention. All right, this is the absolute climax of our timeline. This is what goes down when the heart completely fails to generate effective blood flow. Pulses vanish, the patient collapses. Cardiac arrest is very often driven by fatal electrical malfunctions in the heart, known as lethal dysrhythmias. First up is ventricular fibrillation. Think of this as a completely disorganized, ineffective quivering of the ventricles. It pumps absolutely zero blood. Next is ventricular tachycardia, an insanely rapid rhythm starting in the ventricles that almost always spirals straight into an arrest. And finally, asystole. This is the complete, total absence of all electrical activity in the heart, the flatline. Now, for patients in ventricular fibrillation or ventricular tachycardia, the single most critical intervention is defibrillation. Defibrillation means shocking a chaotic fibrillating heart with a highly specialized electric current. It's pretty brutal, but it acts as a totally necessary reset button for the heart. You see, cardiac muscle cells have this amazing property called automaticity. They can actually contract without nervous system stimulation. So by temporarily stopping all that electrical chaos with a massive shock, the goal is that the heart's natural pacemakers can wake up, reassert control, and restore a normal, rhythmic beat. Let's look at how this all comes together. How do you take the absolute panic of a cardiac arrest and turn it into a precise, life-saving sequence? First, preparation. You get those automated external defibrillator or AED pads right onto the bare chest. Second, everyone stands clear to perform defibrillation if the machine advises a shock. Third, and guys, this is absolutely critical, you immediately resume high-quality CPR right after the shock to manually circulate that blood. And fourth, coordinating rapid transport and management with advanced life support personnel. It is quite literally a highly choreographed dance against the ticking clock. And if that choreography is executed perfectly, we reach the ultimate goal, ROSC. That's the return of spontaneous circulation. It is the miraculous return of a pulse and effective blood flow in a patient who was just previously in cardiac arrest. Literally everything we've covered today, from understanding the slow buildup of atherosclerosis, to decoding chest pain with OPQRS, to rapid defibrillation, all of it exists just to make ROSC a reality. So I'll leave you with this provocative thought. Knowing that someone's survival depends almost entirely on how fast the people around them recognize these warning signs, would you know what to do if the clock started ticking for someone right next to you?